right. Are the slides showing okay?
Yes, perfect.
Yes. Okay, great. Thank you. So good morning to those on the West Coast. Good afternoon to those on the East Coast, which is where I'm at right now in New York. And welcome to the webinar. My name is Lillian Polanco-Roman. I am a licensed clinical psychologist, licensed in the state of New York. I am an assistant professor of clinical psychology at the New School for Social Research, and a little background on my training and about my my professional background. Essentially, I completed a postdoctoral research fellow at Columbia University in the Department of Psychiatry, Division of Child and Adolescent Psychiatry. I also completed most of my, all of my clinical training in New York City, largely in Manhattan and in the Bronx, working largely with racial and ethnic minority youth, including Latino, Latinx, Hispanic youth, and Spanish-speaking families, and many immigrant families. And so this is very much an area that is of particular interest and passion for me, both clinically and research-wise. So with that, let's begin. And so the objectives for this webinar are several. First, I'd like to help you identify some trends in suicide deaths or suicide rates, as well as suicidal thoughts and suicidal behaviors, which are among the most well-supported risk factors for identifying suicide risk. Particularly in identifying these trends among Hispanic and Latinx adolescents and young adults in the US. I'd also like to review some risk and protective factors that have been associated with suicidal thoughts and behaviors. This is essentially culling some of the evidence in the suicide research for the last 50 to 60 years. And so what have we gathered over this course? I'd like to move then to highlight culture-specific risk and protective factors that are associated with suicide-related risk, particularly among Latinx and Hispanic youth. I'd then like to review a screening tool for suicide-related risk that is a recent tool, and there are great national efforts to use this tool, and I'd like to highlight how this tool might help in particular for Hispanic and Latinx youth, and then close with a review of suicide prevention programs that are currently in existence that are specifically tailored to address suicide risk in Hispanic and Latinx youth. And so before I go into the contents of the webinar, I'd like to review a few terms that I will use throughout the webinar. And so just to assure that we're on the same page about when I use these terms, especially since oftentimes there can be some conflation among the terms or some confusion around the terms. And so when I say suicide or when I refer to suicide, I'm referring specifically to a self-directed, injurious or harmful behavior that has led to a fatality or that is fatal. And so a suicide death is another way to reference suicide. And then there are suicide ideation or thoughts, which are as described or as stated. These are thoughts in reference to suicide or in reference to trying to kill oneself. And so these can range from passive thoughts, which could be a death wish or a desire to no longer want to be alive. And that's one end of the spectrum. And then to the other end of the spectrum, we could have more active suicidal thoughts where there is a thought out plan, strong intent to carry out this plan, and ways to access the means to carry out the plan, etc. And then we move on to suicide attempts or suicide behaviors, and these are inactions of the thoughts. And so this is when the thoughts have now transitioned over to actual behaviors, and now the thoughts are being carried out. Youth can refer here to either adolescents or young adults. If I'm specifically talking about one group, I will clarify that, whether it's adolescents or young adults. And if I refer to youth together, it's generally inclusive of adolescents and young adults. And then Hispanic and Latinx I will use interchangeably. And okay. So before you are the suicide death rates for individuals identified as Hispanic or Latinx. And specifically, I'm presenting the rates for males, and this is for the year of 2017. This data is gathered from the Centers for Disease Control and Prevention, and I'm presenting the rates by age group. And so along the x-axis, you'll see age groups, with younger age groups starting from the left and moving to older age groups toward the right. And then along the y-axis, you'll see the rate per 100,000, which is how the CDC presents a lot of these public health data. And two things that I'd like to note. One being the high risk period for suicide rates or suicide deaths within Hispanic males in the US. One is older age, right? And so if we look toward the right part of the graph, we'll see 80 to 85 plus is a particular high risk period for suicide death in Hispanic males. But then if we move to the left, we'll also see a high risk period in young adults, and this is 20 to 24. And so this is a particular high risk period. And this is in contrast to what we saw about 20 years ago. And so now I'm presenting or including onto the graph suicide rates for Hispanic males by age group back in 1999. And that's presented by the gray graph, right? The orange graph continues to be 2017. And you'll notice a couple of things, or two things in particular that I'd like to point out to you. The dramatic decline among the older age group, right? And so we see in 1999, this drop to 2017. And then if you move to the left of the graph, you'll see an increase in young adults, where, and let me present the rates that might help display that a little more clearly, right? So if we look at 1999, rate per 100,000, suicide rate per 100,000 for 15 and 19-year-olds was about 9 per 100,000. In 2017, 12.5. And then for 20 to 24-year-olds, we see the rates in 1999 were about close to 11 per 100,000. And in 2017, it's up to almost 19 per 100,000. So these are pretty significant increases over the last 20 years. And in contrast to what we see in other age groups, like in older age groups, where there's been this drastic decline. Similarly, we see that in females as well. And so we see another point that what I'd like to highlight here is a high risk period in females is adolescence and young adulthood. And so here, again, we have age groups along the x-axis. We have rate per 100,000 along the y-axis. I do want to point out a difference in the scale. And the scale is smaller in females than it was in males, because females have lower suicide rates compared to males. Males are more likely to die by suicide than females. And this is something that we see across racial and ethnic group, and not specific to Hispanic groups. And also something that we see cross-nationally outside of the US. For the most part, there are some countries where we don't see this gender disparity. But specifically with regard to the Hispanic group, I'd like to point out the high risk group among Hispanic females is adolescents and young adulthood. And then as age, with increase in age, we see this gradual decline in suicide rates. But if we look at 1999, 20 years ago, we see some stark differences. We see some of the similar patterns that we saw in the male rates, right? We see 1999, there was this increase, there was this the highest risk period was in older adults, and that's now since declined. We now see that that's no longer the case 20 years later. But if we go to the left of the graph and we again look at adolescence or young adulthood, we see an increase. So specifically, here are the rates. 1999 for the 15 to 19-year-olds, the rate was 2 per 100,000. And then in 2017, it's about 4, a little close to 5, if we round up. And then among 20 to 24-year-olds, we see that the rate was 1.6 in 1999, and 2017, 3.9, almost 4 per 100,000. And so they've essentially doubled for both groups, indicating this increase, and potentially a disparate or a disproportionate increase between males and females. And so we're not quite sure how to explain that increase in youth suicide death rates. There are some ideas out there that are current lines of inquiry that are being investigated and examined. One of which that comes to mind is social media, which has garnered a lot of attention, although the findings remain mixed. And so there's not such strong consensus or confidence in attributing the increase to, but definitely something that is currently under a strong investigation. But we do have a better understanding of what might be driving the gender difference in suicide rates. And so here I present to you the methods or the means by which Hispanic males and females have died by suicide in 2017. This continues to be data from the CDC. And if you look to the left, these are the females between the ages of 15 to 24. And the method or the mean that accounts for the largest portion of suicide is suffocation or hanging, which falls under the category of suffocation, really asphyxiation, is the main, the accounts for the majority of suicide death in Hispanic females. If we look to the males to the right, the graph shows that firearms accounts for the majority of suicide deaths in Hispanic males. And so firearms are more lethal means. And so attempts with the use of firearms are more likely to be fatal and lead to a suicide death. And so this helps us understand some of the gender disparities that we're seeing. Okay, and so now I'm shifting from suicide deaths to suicide ideation, suicide plans, and suicide attempts. And these are, as I noted earlier, well supported indicators of suicide risk, of an eventual suicide death. And so to orient you a bit to this graph here, we have the prevalence rate of past year. So if they've ever thought about suicide in the past year, if they've ever made a plan, if they've ever made an attempt in the past year. And this is among high school Hispanic students or Latinx students. And the data is gathered from the Youth Risk Behavior Surveillance. And this is a nationwide survey that is administered to public and private schools throughout the country. And so presented here are the rates for Hispanic or Latinx identifying students. And the orange lines represent the females, the girls, and the gray lines represent the boys or the males. And what you might notice, and so I have the rates here for the past, again, 20 years, from 1999 to 2017, which is the latest available year for this survey. And then the percent of those who responded yes along the y-axis on the graph. And so what you'll notice if you track a pattern across the 6 different lines, a decline roughly from 1999 to about 2009. Right, there's a bit of a decline across the ideation, plan, and attempts in both male and female. And then from 2009, there's this bit of an uptick, right? And so that's something that's stood out within the past decade in particular. And so we see for suicide ideation, rates for Hispanic females are about 25%. So about 25% of Hispanic females or Latina adolescents report having ever thought about suicide or seriously considered suicide. And then if we look at the solid line, which represents suicide attempts, that's about 11%. So about 11% of Hispanic females or Latina adolescents report having ever made a suicide attempt. And this is in contrast to what we see in males. And so in males, we see about 11% of Hispanic males or Latino adolescents report having ever thought about suicide, and about 5% have ever made an attempt. And so what we're seeing here is a bit paradoxical, where we see higher rates of suicide in males versus females. When we look at ideation and attempts or thoughts and behaviors, we see higher rates in females compared to males. And so there's the bit of a paradox. And there's similar data available on young adults. And so these are 18 to 25-year-olds. And so here I'm presenting, again, the prevalence rates of ideation, suicide plan, suicide attempts in Hispanic young adults, 18 to 25. And this is data collected from the National Survey on Drug Use and Health for the last 10 years, so for the last decade. And so what you'll notice that the two bottom lines, the orange represents the plans, the green represents the attempts, is this slight increase from 2009 to 2018. But if we look at the gray line on ideation, we see a more pronounced increase. And so something else I'd like to point out also, if we look at the y-axis, it's a smaller scale, which indicates that there are higher prevalence rates of attempts and ideation in adolescents compared to young adults. And so if we look at young adults, we see the increase within recent years, within that 10-year period in particular, but the prevalence rates continues to be lower in young adults and higher in adolescents relative to each other. And I also want to point out some early studies that have examined within group differences, that is, subgroup differences in the prevalence rate of ideation and attempts in adults in the US, specifically within Hispanic adults in the US. And there's evidence to suggest that individuals of Puerto Rican background in particular might be at elevated risk. And so these studies, if you look at along the bottom of the graph, along the x-axis, you'll see the lifetime rate for suicide attempt represented by SA, and then the lifetime rates for suicide ideation represented by SI. And this was examined in 3 different epidemiological studies. So these are large data samples that are nationally representative. And in 3 different studies, a similar pattern was detected, which was that Puerto Rican individuals or individuals with Puerto Rican backgrounds seem to report higher prevalence rates. And that's represented by the blue bar. And so that's consistently emerging across the 3 different samples. And so this, unfortunately, we don't have comparable data with youth, so with the adolescents or young adults in particular. And so it's hard to generalize these findings to younger populations. So that is the information, that is a significant gap in the literature, but nonetheless, this can inform some of our approaches. So the takeaway from the data that we've gathered so far are twofold. One is young adulthood in particular is a high-risk period for suicide in Hispanic and Latinx populations. And so it is essential to act early. Early detection is critical. And another takeaway point is that within the past year in particular, we've seen an increase in suicide-related risk as evidenced by rates of ideation and behaviors. And so taking that into consideration and knowing that 50 to 75% of youth under the age of 25, these suicides are first attempts, really highlights the need to detect early. And so if we're relying on a history of suicidal behavior, for instance, which is a strong marker or indicator for suicide risk, for the majority, a history of suicide attempt might not be informative. It might not be helpful. It might actually be too late, right? And so if up to some studies even estimate up to 75% of youth suicides, those under the age of 25, are first attempts. And so if that many are first attempts, it means we really have to act sooner before we start even seeing behavior before the onset. And so when we look at the findings on the onset, age of onset, we see that onset generally is around adolescence, late adolescence for suicide attempts. So that's around age 14, age 15. And then that's typically preceded by an age of onset for suicide ideation, which was maybe a year or 2 earlier, so around age 12. Around age 12 is when we start to see ideation, or when we start to see an uptick or a surge of when youth start thinking about suicide. And a year or 2 after that is when those thoughts transition into actual attempts. And so as I've noted and showed in earlier graphs, onset peaks in adolescence. And so in adolescence where we see a surge. But what happens is the severity of the ideation and of these attempts increases through young adulthood. So through young adulthood is when attempts are more fatal or require hospitalization or medical intervention, or attempts become more frequent, or shorter distance between one and the other. And so in young adulthood in particular, there's this urgency to act. Okay. Fortunately, we've, through the last 50 to 60 years, we've been able to identify risk and protective factors that could predict when one might think or make a future attempt. And so this might help us better identify and identify earlier before onset. And so first I'll start off with some of the intrapersonal factors. And so these are factors within the individual or of the person, of the youth. And I want to highlight that this comes from a comprehensive review paper by Christine Cha. And it was I listed on the reference for those who might be interested in going through it more carefully. But it's a very comprehensive and thorough paper that highlights risk factors, particularly among youth, because over the course of our studying of suicide risk, what we've come to see is that while there may be some overlap in risk between youth and adults, there are some factors that are specific to youth, and so this is important to distinguish. So I noted that a history of suicidal behaviors is among the most robust predictors for future suicide attempts, but also that might be too late if we're waiting for a history. And so we also know that psychiatric disorders are also associated with elevated risk. We also noticed a difference here as well. So with the adult literature, we see that about up to 90% of adults who die by suicide had a psychiatric disorder. But when we look at youth suicides, only about a third of youth had a psychiatric disorder. And that was covered, that was a research paper that was done by Ariel Shefdal. That's also cited in the references for those who are interested in reading more about that. But for that study, they examined youth suicides among individuals 14 and under, and conducted a psychological autopsy study to find out more about these youth. And one of the findings that emerged were that only a third of those youth had a psychiatric disorder. So something to keep in mind. Risk behaviors are also a robust or a reliable indicator of suicide risk, particularly if we're thinking about alcohol use, misuse, substance use, misuse, and sexual risk behaviors like unprotected sex and early age. And so those are markers for suicide risk. Child maltreatment, particularly sexual abuse history or physical abuse history, are strongly associated with elevated suicide risk, but also emotional abuse and neglect have also been linked to suicide risk. And research also shows an additive effect. And so youth or who have multiple exposures to different types of these adverse experiences are at even further risk. Impulsivity related traits are also linked to associated to suicide risk. And so seeing children or youth who have difficulty regulating their behaviors and with premeditated thinking or difficulties with inhibitory control are strongly associated with elevated risk. And this ties in with emotion dysregulation. And so difficulties regulating emotions and such as having emotional outbursts, etc. So these are the intrapersonal factors. And so now I'll move over to the family factors that have also been linked to suicide risk in youth. And so one of which is a strong one is a history of suicide or suicidal behaviors, particularly first degree relatives. Siblings and maternal history are among the strongest. Family history of psychiatric disorders is also associated with elevated risk. Early maternal age, and so that's also consistently linked to higher rates of suicidal behaviors in youth. Poverty, right, low SES, is also associated, and also intimate partner violence between the parents. And so if the parents have a history of intimate partner violence, especially if the child has been exposed directly, or even indirectly, there's evidence to indicate that that also poses greater risk for youth. And there are also interpersonal or social factors. Many of these come from Thomas Joiner's interpersonal psychological theory of suicide model, where he highlights perceived burdensomeness, which is a feeling that if the youth feels that they are a burden to their family, could be an indicator of risk for particularly suicidal thoughts or thinking of suicide, which can put them on that trajectory for suicidal behaviors. And thwarted belongingness is also another element or social factor that has been linked to suicide. And this is feeling, it's different from loneliness, but it taps into some of those feelings of loneliness. And so, and more recently, what's been garnering some attention is bullying and peer victimization, right? And so youth that are experiencing bullying from peers in particular are at higher risk for thinking about suicide and for attempting suicide. And then lastly, I'd like to highlight some community level factors that have been linked. And so exposure to community violence, and oftentimes this is captured, not oftentimes, but it can be captured as an early life stressor or as an adverse childhood experience. And in addition to the more traditional adverse childhood experiences, such as child maltreatment, as well as parental maladjustment, so some of the parental factors that I've highlighted. And so, but if we think about the additive effect that adverse childhood experiences might have, and if we think about exposure to community violence and the disproportionate exposure of community violence in Hispanic and Latinx youth, we can see how these added adversities can have a particular or a disproportionate impact or burden on Hispanic and Latinx youth. Neighborhood poverty, which is not necessarily different from family or household poverty, which was highlighted earlier in the family factors, and contagion. And so contagion, referencing exposure to suicide or suicidal behavior, either within through some network or some community, so through school, within the neighborhood, within the family even. And so this recent exposure is also associated with elevated risk for suicidal behaviors in youth. And then you might notice that there's a shorter list for protective factors, but there have been protective factors that are associated and then have been incorporated or used specifically for reducing risk and have shown to be useful in those ways. And so social connectedness, right? And so it's connectedness either through family or through peers or through school has been associated with lower risk. Reasons for living. And so if a youth can articulate or generate reasons for living, that's typically associated with lower risk. Feelings of hope, and so promoting hopefulness can help reduce risk or has been linked to lower risk. Social support, right, which can tie into some social connectedness, but it's different. So it captures different elements. And then of course, interventions, right? And so interventions that can leverage some of these protective factors and also attempts of reducing the risk factors that were identified. And so we know that intervention can be helpful in those ways. So knowing all of this and knowing that these are essentially the findings or what we know of suicide research within the past 50 or 60 years, and also recognizing that a lot of this research comes from clinical samples that are largely underrepresented by or of Hispanic and Latinx youth. And so what comes to question are the generalizability of these factors on Latinx and Hispanic youth, but also a lot of it requires, by the time you're in a clinical setting, there's an onset of either suicidal thoughts or behaviors. And so by then, is it too late? Are there things that we can do to start sooner? And so I'll get a little more into that in a few minutes, but before I get into that, I do want to note that more recently, there are findings to suggest that there may be some culture-specific risk and protective factors that apply to Hispanic and Latinx youth. And a lot of this research has come from investigations on the role of acculturation and suicidal behaviors. And so one study in particular, using a nationally representative sample of Hispanic and Latinx adolescents, found that later generation youth, that is youth who were born, Hispanic youth who were born in the US and their parents were also born in the US, had higher prevalence of suicidal thoughts and suicidal behaviors compared to early generation youth, or youth who were born outside of the US, or youth who were born in the US, but their parents were born outside of the US. And so this finding indicates or suggests or alludes to the potential role of acculturation in suicide risk that might be particularly relevant in Hispanic and Latinx youth. Not specifically, but it might also apply to adults as well. But so it has launched this inquiry, or this line of inquiry, to better understand the role of acculturation in suicide-related risk. And so kind of a follow-up study to this. The next study used a nationally representative sample of adults. And so this is adults more broadly. And they were able to essentially replicate the findings and found, but this study looked at different markers of acculturation, specifically looking at age of migration. And what they found was that an earlier age of migration, so those who've migrated to the US before the age of 12, that was associated with higher rates of suicide ideation and attempts. They also noted that a longer residency in the US was associated with higher rates, and greater proficiency in English was associated with higher rates of suicide ideation and attempts. Again, further supporting this idea that there's something about the acculturative process that potentially might increase risk for suicide. So greater levels of acculturation are associated with greater risk of suicide ideation and suicide attempts. So some of the research that has launched, or some of the information that those research has yielded, are some identified culture-specific risk factors, one of which are, or broadly defined, cultural stressors, but we can unpack that a little bit to better understand what are some of these cultural stressors that are prevalent and common in the lives of Hispanic youth, and that could potentially confer or impact risk for suicidal behaviors. And so one is racial and ethnic discrimination, or unjust or unfair treatment based on one's racial or ethnic group affiliation. So there's a growing body of research showing that higher levels of discrimination are associated with higher levels of suicidal thoughts and behaviors. And this has been found also in Hispanic and Latinx youth. Not exclusively, there's also indications of this relationship in other racial and ethnic minority groups as well. Minority stress is another form of cultural stressor that could also increase risk, and acculturative stress. And so specifically thinking about acculturative stress in the many ways in which that can manifest. And so one way is acculturation gap stress. And so if there's an acculturation gap between the parent and the youth, and so research showed that parents are acculturate at a slower pace than the youth. And so this discordance in the pace of acculturation might yield some conflict within the family that could elicit some stress. But also acculturative stress can come from language barriers, pressures to assimilate, and other experiences that result from the acculturation experience. Culture-specific protective factors have also been identified, and one of which is ethnic density. And so research has shown that Hispanic or Latinx individuals who live in ethnic enclaves or in neighborhoods or areas with a high proportion or representation of other Hispanic populations or immigrant populations have lower rates of suicide compared to individuals who live in areas where Hispanics are underrepresented. And so there might be something about, it could be a sense of community that comes through this ethnic density effect. It could be social networks. It's not quite certain what it is specifically about ethnic density that could potentially reduce or attenuate risk for suicide, but that has been identified. Another thing that it could be linked to and that has received support are racial and ethnic identity, or a sense of pride around your Hispanic culture, Latinx culture, and that had been linked with lower risk or lower risk for suicidal thoughts and behaviors. And so that's something that's been pretty well supported, and also demonstrated in youth and adolescents and young adults in particular. Religiosity or spirituality has also been linked to lower risk, and so it's been identified as a culture-specific protective factor, particularly not necessarily religious practices, but more religious coping or more internalized religiosity, and so coping styles, for instance, in particular. And familism. Familism has also been linked, and familism being putting the needs or prioritizing the needs of the family above or over the needs of the individual. And this has been linked. This has been shown to potentially reduce risk through promoting family cohesion, reducing family conflict, promoting mutuality between parent and youth. And so through these factors, or potentially through these pathways, familism might reduce or protect against suicide risk. And there are other factors. These are not necessarily culture-specific factors, but these are certainly racial disparities in factors that associate with suicide risk. And so, as I mentioned earlier, intervention can reduce risk for suicide, but we see low mental health service use in Hispanic and Latinx youth. And so, particularly those who have suicide risk. And so those youth who have shown a history of suicide attempt or a history of suicide ideation. And so if they're not accessing these services, then that then puts them at greater risk. And there's also evidence to suggest that racial and ethnic minority youth are less likely to disclose to others that they're thinking about suicide or that they've made an attempt, for instance. This hasn't been examined specifically with Hispanic or Latinx youth, or if it has, I'm not aware of that literature. But this is particularly has been examined with Black youth, and so that's something to keep an eye on. The good news is that given what we've learned over the course of the last 50 or 60 years of suicide research, that's yielded suicide prevention strategies. And these suicide prevention strategies, well, first you can see a variety of them, right? I won't go through the entire list, but you can just see the variety of suicide prevention strategies, from individual psychotherapy such as CBT, DBT, or psychodynamic psychotherapy, to school-based programs, which are highlighted there, community-based interventions, to more, broader public awareness campaigns, for instance. And so the good news is that most of these interventions suggest that there's a high level of effectiveness in them. So many of them are effective in being able to reduce risk. The concern then is, whether it's bringing them to these interventions, bringing the youth to these interventions. So if they're working, but they're not being utilized, then they're not really working, right? And so how do we bridge that? And also a concern is many of these interventions are kicked off after an attempt has been made by a youth, or after a youth has disclosed suicidal thoughts. And at this point, we're approaching that onset, that small window, and might this be too late? And so this has driven efforts that are trying to cast a wider net to try to detect risk before a youth even presents to a clinical setting with suicidal thoughts or behaviors. And one way to do that is through wide screening youth in emergency departments, because we see that children, adolescents, and youths more broadly are more likely to access ED services, emergency care services, more than mental health services, but also more than our other health services as well. And, oh, sorry about that. And so, yeah. And so, I mean, really the most reliable way, the most robust way to find out if a youth is thinking about suicide is essentially to ask them, right? And so a barrier, a long-held barrier to this was asking children or adolescents could potentially increase risk, right? Because it might induce suicidal thoughts, or it might plant some seeds, or some plant some ideas in a child's head. But the findings just doesn't support that. The findings don't support that there are iatrogenic effects in asking children or adolescents if they're thinking about suicide. If anything, it's the opposite, that asking children, particularly if they are having thoughts, is most helpful, because the harm is if a child is having these thoughts and they're not being asked, then they're suffering in silence and continue on this risk trajectory. And so this has helped promote a wider effort to screen children in emergency departments, even children who present to the emergency departments without suicidal ideation or suicidal attempts, even if they're just presenting with a medical problem, to try to screen all children who present to the ED for suicide risk. And so a tool that is recently developed and is being publicly available. This was developed by the National Institute of Mental Health, and this is this is a tool that is being provided so that more people are able to conduct these screens for risk. And so they were developed to be used in emergency departments, in inpatient clinics and outpatient clinics, but the screen was also promoted to be used in other settings where you might encounter or work with youth. So in schools or juvenile detention centers, right? And so these settings where there might be a mental health professional or a clinically trained professional who could assess or screen for risk and then take the necessary steps depending on what is detected. And so this is the Ask Suicide Screening questions. And so it's pretty straightforward. It's very brief. It takes just a few seconds to complete. And depending on the responses to the screen, then one determines whether they'll go on and complete a safety assessment, which I'll go over in a little bit, or if a full evaluation is necessary or a high level of care is necessary. And then this is when a referral is made to a more higher level of care setting. And so, yeah, it's essentially trying to get at whether the youth has thought about suicide or death, or really thought about suicide, but using more age-appropriate language, and also trying to get at different ways in which children might have these thoughts, right? So have you wished you were dead? Have you felt that you or your family would be better off if you were dead? Have you been having thoughts about killing yourself? And then attempt, have you ever tried to kill yourself? And so if no is the response to all of these questions, you move on. It seems like risk is low, and then you can provide some resources. The full tool will provide some hotlines that the youth can use if they ever have these thoughts. This could generate some conversations about what to do if something like this ever does come up for them. And then if they respond yes to any of these questions, then you move on to question number 5, which is, are you having thoughts now of killing yourself right now? And this taps into acuity, right? And so the tool walks you through, which is really nice about this tool. It really walks you through the different types of responses and the different next steps. And so if they respond no, as I mentioned, to all of those questions 1 through 4, there's no need to inquire about acuity. Or question 5, you can provide resources. Here's the lifeline if you ever do have thoughts. Here's a text line that you can text if you ever do have thoughts or if you're ever concerned. And if they answer yes to questions 1 through 4, and then they say no to question 5, again, you'll go ahead and provide a safety assessment, which I will go over right now. If they respond yes to the acuity question, the positive screen, imminent risk is identified at that point, and there a full mental health evaluation is recommended. And so if within your clinic or setting, you're able to provide this higher level of care, if not, then the recommendation is that you refer to a setting where they're able to provide a more thorough, full mental health evaluation. And so this is the screen. This is just to see if a safety assessment is required. If you determine that a safety assessment is required, then you move on to this portion of the tool set. And it's really helpful. It really just walks you through. You have scripts that you can follow, that you can say, right? And so first you're instructed to encourage the youth for discussing their thoughts, right? Reinforcing that so that they know that this is how you can best help them, and try to do away with the stigmatization of having suicidal thoughts or disclosing suicidal thoughts. And then you kind of just go through a lot of the risk factors that we identified or reviewed earlier in this webinar. And so you're going to go into more detail about into more content of the suicidal thoughts. So if they've been thinking about it, how often have they been having these suicidal thoughts? If they have developed a suicidal plan, and if so, you want to get more detailed information about the suicidal plan. What is your plan? If you were going to, how would you have done it? And then once you get a plan, then you want to know if they have access to the means. And so if their plan was to take a bottle of pills, you want to know if there are bottles of pills that are accessible to them, because then that can be helpful later on when you're developing more of a safety plan. And then you want to get into the history. You want to know if they've ever made an attempt to kill themselves, and you want to collect thorough information about that. And then you also want to assess their current symptomology, their presentation. What are their symptoms? Are they presenting with depression? Are they depression symptoms, anxiety, impulsivity? A lot of the substance use, alcohol use, a lot of the risk factors that were identified earlier. And then you also want to identify protective factors. So, and this is towards the bottom now, we're looking at the social support and the stressors. Does the youth have social support network that they can turn to? Is there a trusted adult that they can turn to, that they can talk to, that they trust, a counselor or a therapist? What is their family situation like? Is this family situation where there are conflicts at the home, or is the family a support network or part of the support network? What is their school functioning looking like? And also, I'd say their school situation. Is there someone in the school setting that they trust or that they can talk to? Or you want to assess if there's bullying. Also, if there's suicide contagion, if they know anyone who has killed themselves or who's tried to kill themselves. And also the reasons for living. What are some of the reasons you would not kill yourself? Or if you had thoughts, what were some of the reasons that you did not carry out the thoughts? And the next step would be to interview the parent and the youth with the parent together. And so here you're essentially corroborating what the youth has told you individually, and now with the parent, with the youth, it serves a couple of purposes. One of which is knowing that the parent is part of the process, and also you're getting two sources of information, so that can help determine some I guess, reliability or accuracy in what has been reported, or even to know what the parent knows, right? Gauge what the parent's level of knowledge is, or gauge their level of investment in this process. And so here you're given some scripts about what you can say to the parent to help, and a lot of it is many of which was already asked to the youth. And so, and then once you're moving forward with that, you make a safety plan with the youth. This should include the parents as well, or the guardian, right? And so again, a script is provided, and here you're helping the youth generate ways in which they can manage the next time they have thoughts of suicide, or when they start to have thoughts again. What can they do? And identify people that they can turn to. You know, can they turn to their mom, their dad, a coach, a teacher, a counselor? They can call the hotline or the text line. You can try to generate coping strategies that they can use to manage their distress. Things that are commonly recommended, or self-soothing techniques like taking deep breaths or listening to music, or whatever it may be that the youth might say helps them feel better, or can help them distract themselves from the suicidal thoughts. You also want to discuss means restriction. That is, whatever they might plan to use to carry out their plan for suicide, you want to minimize that, because means restriction has been shown to reduce risk, because giving just an extra couple of seconds could be the time that they need to come down from that suicidal crisis moment. And so if there are pills in the home, you want to discuss with the youth and with the parent about putting the pills, safeguarding the pills in a locked cabinet somewhere where it would be difficult for them to access, and similar strategies like that. And then you want to ask a safety question. If they feel that they need help to keep themselves safe, that they won't be able to keep themselves safe on their own. And so this can kind of alert you to some more imminent risk. And then based on what you detect in terms of the risk factors and the protective factors, then you can determine your next steps, right? And so if you see a long list of risk factors, a short list of protective factors, then it's likely that a full mental health evaluation is necessary to better assess the risk level at this point. But if you see that you have this short list of risk factors, you have a very involved and engaged parent, they have a lot of support built around them, and it looks like risk is lower, then you can help create a bridge between the youth and the mental health service provider. And so you can offer a referral and follow up and see if they've been able to follow through with the referral, and how have things gone in the interim. And then again, you provide the national hotline information and the Texas Crisis Line, and it's available. And so this is just an example of the ASK screening tool. And as I noted, there's also one for inpatient and for the emergency department. This one is particularly for the outpatient setting. And so they're trying to roll out this tool and make it very widely accessible to folks. You can go to their website, and they give you tutorial videos and more information about how to become more comfortable and how to familiarize yourself with using this, and etc. This also comes in the screening. I don't know that the full safety assessment, but the screening tool comes in 13 different languages, including Spanish, and so that's also helpful. And so knowing that teens are very active in technology, there has also been efforts to move some of these strategies to applications, phone apps. And so presented here are a couple of the phone apps that use essentially a safety assessment that I just went over with the screening tool, the ASK screening tool, that have been applied into these mobile apps. And so to the far left, it's one called Blue Ice. That one was developed out of the UK. And if you look at the different options, you'll see These are some soothing strategies or some safeguard measures that a youth can turn to if they're going through a suicidal crisis or a suicidal moment, and so they can tap into try to get active or do something or identify thinking traps. And so a lot of these apps use more of the evidence-supported individual therapy approaches. So like thinking about CBT or DBT strategies. And so if we know that youth are on their phone, and if they're going through a suicidal moment and they have their phone right in their hands, they can turn to these apps to help them in that moment. Virtual Hope Box is another one. I think this one was developed in the US for military populations, but has become more widely used. The one to the right, Bright, is currently under development. It's not available to the public just yet. The other two are free and available to the public. The one to the right is still under development and is still being tested, but it seems promising and functions very similar to as I've described the other apps. And then the one at the bottom, Boobly, was one developed in Australia for Aboriginal populations. And this one incorporates more culture-specific approaches. And so that's one way that this one stands out to compare to the others. But this seems to be a direction that suicide prevention strategy is taking, learning how to incorporate technology, especially when addressing suicide risk in youth. So before I wrap up, I want to highlight some existing suicide prevention programs that specifically target Hispanic or Latinx youth. And these programs have used a lot of what the research on acculturation and suicide risk has yielded, one of which is Life is Precious. And this is one of a growing program that has been quite successful in recent years. It started out as one site in the Bronx and now has 4 different sites across the New York City area. And this is an after-school community-based program. It's intended to supplement mental health services, so it's not intended as a clinical service. It's intended to supplement clinical services, so the youth might be in receiving mental health services elsewhere. But through this program, they receive support in other areas of their lives. So they receive support through their academic functioning, through peer and family relations, through college and job readiness. And so it's really meant to be this support, to provide this support network and a support system for the youth. And another program that functions similarly is the Familias Unidas. And this program was originally developed to target substance use and sexual risk behaviors in Hispanic youth. And it's a family-based program, so it targets family dynamics in particular. And in testing the effectiveness of the program, what the developers realized that there was a crossover effect. And so they noticed that youth were also reporting lower risk for suicide. And so now the program is used as a suicide prevention program as well. And so it's family-based. They target family communication. They try to promote family cohesion, family connectedness, and the evidence suggests that it's quite effective. It's also been working pretty well and growing. They've recently started implementing some sites in Latin American countries, in Ecuador and Chile in particular. So those seem promising. And a more recent program, or rather, this is a treatment protocol that's in development, and that also seems promising, is the it's called the Socio-Cognitive Behavior Therapy for Suicidal Behaviors. And this treatment protocol draws on, or expands upon rather, an evidence-supported therapy program through CBT, and it incorporates culture-specific factors. And so it's really a cultural adaptation of CBT to target specifically suicidal behaviors. And so one of the unique elements of this program is targeting cultural stressors. And so they specifically target discrimination stress and a culture of stress. They also highlight identity development within this treatment protocol. And they also incorporate trauma, recognizing the disproportionate burden of adverse childhood experiences and traumatic experiences in Hispanic and Latinx youth. And so that's also an element that is incorporated into this treatment program. And so altogether, you know, there are a few programs, existing programs out there specifically tailored to Hispanic and Latinx youth. And these programs seem quite promising in their ability to deliver and to reduce risk for Latinx and Hispanic youth. And so with that, I want to present some suicide prevention resources. The ASK, which was the toolkit or the screening toolkit, the screening tool and the safety assessment tool that I reviewed a few moments ago, is available, as I noted, in the NIMH website. There's also further resources in the Zero Suicide Toolkit website that's provided from SAMHSA. And so from there, you can, in addition to getting resources in screening for suicide risk, you can also obtain resources for trainings. So if you want to conduct trainings, more setting-wide trainings in your institution or your department, you can obtain some of those resources from there. And then I also want to bring to your attention an After a Suicide Toolkit, which is provided by the Suicide Prevention Resource Center. And this is specifically targeting contagion. And so if a youth is being exposed, if there's been a recent suicide or a recent suicide attempt, these resources particularly help target that, how to talk about and what next steps you can take to reduce risk, specifically relating to a recent exposure. And so with, here the usual National Suicide Prevention Lifeline in English and Spanish, and the crisis text line. And that concludes the webinar, and I thank you for your time, and I open the floor to you for your questions.
Excellent. Thank you, Dr. Polanco, for that great presentation. We have a few questions that I would like to start sharing, and also invite participants to provide questions through the chat throughout this section. One of the questions is regarding the apps that you mentioned, and people wanted to clarify the last app that you mentioned.
Yes, so the last app that I mentioned is iBoobly, IBOOBLY. So this was an app that was developed and created in Australia for Aboriginal populations. And so this one is one of the few that actually incorporates culture-specific approaches to suicide prevention. So they use, it's really tailored to this this population within Australia. So I don't know how widely, you know, or how generalizable or its utility could be, but it can definitely serve as a model for how we can create apps similarly. So we could potentially, you know, try to develop or promote the development of a suicide prevention app that could be tailored specifically to Latinx or Hispanic youth.
Excellent. Thank you. Another question that we have here is the ASQ screening tool usable in the school setting?
Yes. So the ASQ, the screening, which was the first 5 questions, those brief questions that I went over, that's the screening tool. And that is recommended to be used in schools, juvenile detention centers, anywhere else where you might work with youth populations. And so this screen will help you determine whether a further assessment is necessary. And so through this screen, they want to encourage that. They want to provide, NIMH wants to provide tools so people feel comfortable and competence to be able to assess for risk, because not asking is not helping. And oftentimes we won't ask because we won't know what to do if we find out that a youth is indeed having suicidal thoughts.
Excellent. Thank you. Another question we have here from one of our participants is there any data that talks about links youth who are part of the Latinx community but identify as LGBTQ, and how that puts them at an even greater risk of suicide, ideation, suicide attempts?
Yes, thank you for that question. And so it's very limited. That research is very limited, but from what is available, there is indication of this double minority risk, right? That as an LGBTQ youth, you're at elevated risk, and then as a Hispanic Latinx youth, you're at elevated risk. And so, yes, there is evidence to suggest that, but the research is very limited.
Excellent. We have another follow-up question on the ASQ screener, and are we able to use it as school settings without any copyright issues?
Without any copyright issues? Yes. So this is available. You can go to their website and you can download it, and they describe its use. And so there won't be any issues with there won't be any copyright issues. If anything, if the copyright issues come into play if you're using it and you're obviously you can't sell it, right? You can't make profit off of it or anything like that, but it's publicly available and they want to widely disseminate this.
Excellent. Thank you. One of the questions we have is, what are some of the more common behaviors in teens identified and observable if they are considering suicide? What should caregivers pay attention to?
Yeah. So the caregiver, if they're starting to wonder, if they have any inclination or any indication or concerns that their youth might be thinking about or attempting suicide, my recommendation would be to ask. Ask the youth straight up front. Ask the youth. That's really the most reliable way to know. But there are behaviors that you can observe. No one behavior in particular is going to tell you if the youth is at risk. Usually it's a combination of different behaviors. And so oftentimes if we see, some of the behaviors could be early or misuse of alcohol or substances or drugs, whether that's illicit drugs or prescription drugs. If you see, impulsivity or recklessness behaviors that might be strongly linked to impulsivity or impulsivity-related traits are often good indicators. But then, we also see a class of youth who could be withdrawn, and these might fall into the, more. Not saying that these can't be depressed youth as well, but there could just be very many different manifestations of or profiles of what a youth at risk might look like. And risk might also be state dependent, meaning it might be as a result of something that happened, like a stressor, right? And so sometimes what we see in the literature is that a suicide attempt could be precipitated by a recent breakup or something like that, or in Latinx and Hispanic youth in particular, we see conflict with family. It's like a fight with a parent or something like that. And so it's hard to really pinpoint any one behavior or any set of behaviors, just because there's just such a variation in the presentation. And so really the best way to try to find out is to ask.
Well, I have a question here that follows great with that answer, and is, where could we find information on suicide in Spanish for families? It's a question that we have.
That's a good question. So, the ask comes in Spanish. That's the short screen, the brief screen that comes in Spanish. That could help serve as a guidance to start having some of these conversations about whether the youth is having suicidal thoughts or if they've ever made attempts. But there, there's not that many. There's not a lot of information, and so one really has to search.
Excellent. I'm getting to another question here, and give me just a second. You mentioned higher acculturation increases the risk of suicide. How families can prevent high schoolers from acculturation and at the same time being bullied?
Yeah, that can be challenging, right? Because if the question, if I'm understanding it correctly, is the idea that if you're acculturating, so the youth is acculturating, trying to fit in so that they don't get bullied, or if they're not acculturating or connecting more with their peers, then they might be targeted for bullying. And if that's the case, then part of what can be done is to promote cultural pride. And so that's been linked or identified as a protective factor. And so helping the youth develop cultural pride in their Hispanic and Latinx cultural background. And so this would then promote more of a bicultural identity where they can acculturate and adapt to the mainstream US cultures. And that can be one part of their identity, but they can also keep the strong connection to their family's heritage and their Hispanic and Latinx background. And actually, more recent research is starting to show that it's not adapting the mainstream US culture that's harmful. It's more so the losing the heritage culture that seems to be the harmful piece or the harmful aspect of it. And so through losing the heritage culture, then it might compromise some of the connection with the family and the extended families. And so really promoting more of a bicultural identity seems to be what can be the most protective.
Thank you for that answer, Dr. Polanco. Another question we have here is pertaining the pandemic that we are all facing, and how is this impacting in suicide behaviors in the Hispanic and Latino communities?
Yeah, that is a very good question, and thank you for bringing that up, because I meant to bring it up while I was going through my rates. And so the data is not out yet, although there was a recent survey conducted by the CDC in June, I believe, and early findings. And so there they inquired about thoughts of suicide, they inquired about depressive symptoms, anxiety symptoms, and a couple of other symptoms. And what they found were higher rates among those who were surveyed. And now this was an adult survey, so this was not done in youth. There's currently no information about changes in suicidal thoughts or behaviors in youth available yet. But in this adult survey, what they found was that rates were higher among young adults, 18 to 24-year-olds, compared to older adults. And rates were higher among racial and ethnic minority populations, particularly Black and Latinx or Hispanic adults. And so already we're starting to see racial and ethnic disparities in suicidal thoughts in response to COVID-19. So that's already bringing concern to that area, but yeah.
Thank you. We are approaching the 30-minute mark, and I want to be mindful of the time. So there's a lot of great questions. So I'm trying to just pick through the best and the ones that I think that will be most relevant for everybody. So I have one last question that Dr. Polanco could address before we say goodbye to everybody. So it says, do you have any recommendations for engaging families in conversation about this when we can meet in person due to COVID-19? I work in a school-related setting.
Yeah. So that is tricky, and that comes up, right? Especially now in the age of telehealth and virtual meetings. And so really the fallback to that is working closely with the parent, who lives, or the caregiver, or a trusted adult that is in charge of the child's care, and so through working with that adult, and it's really teamwork. It's a teamwork effort. I mean, that applies to any work, right, with children and youth. And so, so calling in, having a trusted parent, a child caregiver as part of the process, and then also knowing, providing them resources that are accessible to them, such as these apps or the text line or the hotline, if they're ever in a moment of crisis and you know, they're looking or turning to for help, for some help to get through these crises. That's one of the theories or the notions that emerged from this acculturation and suicide literature, a lot of which was led by Luis Zayas, which is this idea that suicidal behaviors could serve as an idiom of distress, is a way for youth to communicate that they're in distress and that they need help and that they're unable to help themselves in that moment. So what can they do to help themselves in that moment? And what we can do is try to provide them with tools, different ways that they can try to help themselves, because the tools that they've had so far have not been so helpful.
Excellent. Thank you, Dr. Polanco. With any more time for more questions, we wanted to go back through some information. The presentation will be available or is available at in your bottom right corner. You can download the handout for this presentation. It also will be available at our page later on this week, as well as the recording for this presentation. That's one of the questions we've been getting, and yes, the presentation was recorded and will be available through our page during the next week or so. I wanted to once again thank Dr. Polanco for her time and this wonderful presentation, and also the folks at the Northwest MACTC. Christina, you wanted some words at the end?
Yes, thank you so much. This was very, very, very helpful and very timely. And I really appreciate the topic and the opportunity to collaborate with you all, and really appreciate everyone's attending today, despite so many things taking our attention away. And so really appreciate everyone's time today, and look forward to having the recording for others that didn't get to make it. So thank you, Dr. Blanco, really appreciate it. And thank you to the National Hispanic and Latino MHTTC. Thank you so much.
Thank you, Christina. I want to remind folks that your opinion for us is very important, and you will be receiving evaluations after this event is over, so you can share with us your thoughts on how we can better our services and continue providing meaningful topics that will help providers better serve Hispanic and Latino populations. In your screen, you have the website for the MHTTC network. Through there, you can access both the Hispanic and Latino and the Northwest MHTTC pages and benefit from all the great resources that we have. Once again, thank you, Dr. Polanco. Thank you to everybody that could attend today.
Thank you for having me.
Have a great day.